Hello, everyone. Thank you for joining us. I'd like to welcome you to this Elder Justice Initiative webinar, Improving Emergency Department Identification of Elder Abuse. Before we get started, we want to take a moment to make sure that everyone is properly connected. So if you're experiencing any technical issues with the audio or with your Adobe Connect, please use the feedback box or the chat feature on the lower right to let us know. You can also contact Danielle McLean through email if you're having trouble accessing the chat. Her email address is dmclean@ovcttac.org. Today's session is being recorded and will be made available on the training websites for both OVC-TTAC and the Elder Justice Initiative at a later date. And if you have questions throughout the webinar, we invite you to use the chat feature to ask those questions of our presenters. We'll get to as many of those questions towards the end of the webinar as we can. I do want to take a note here to make note that due to the nature of today's topic, there may be some content or images that some can find disturbing, so we ask that you use your discretion when viewing. And at this time, I'm going to turn things over to our host, Dr. Sidney Stahl, a research consultant with the Department of Justice Elder Justice Initiative. All right, Sid.
Thank you. Good afternoon, everyone. This is Sid Stahl. I'm pleased to have Dr. Anthony Rosen with us today talking about improving emergency department identification of elder abuse findings from forensic research. This webinar is part of the Elder Justice Initiative of the U.S. Department of Justice. The mission of that initiative is to support and coordinate the Department of Justice's enforcement and programmatic efforts to combat elder abuse, neglect, and financial fraud and scams that target older individuals. This mission is accomplished by promoting justice for older individuals, helping older victims and their families, enhancing state and local efforts through training and resources. And today's forensic research webinar is part of the last of those activities, that is supporting, organizing, and presenting research to improve elder abuse practice and policy. The initiative, one of the products of the Elder Justice Initiative is the Elder Justice website, which we invite you to take a look at your leisure. We're delighted today to have Dr. Rosen present his work on forensic research in emergency department settings. Dr. Rosen is a researcher in elder abuse and geriatric injury prevention at Weill Cornell Medical College and a practicing emergency physician at York-Presbyterian Hospital. His many research publications explore forensic injury patterns in physical elder abuse. He has been supported by several National Institute of Aging NIH grants, most notably the highly prestigious Beeson Award. Dr. Rosen has also led the development of an emergency department-based multidisciplinary vulnerable elder protection team to assess, treat, and ensure the safety of elder abuse and neglect victims. Dr. Rosen serves on the executive committee of the Academy of Geriatric Emergency Medicine, the steering committee of the New York City Elder Abuse Center, as well as on multidisciplinary elder abuse response teams in both Manhattan and Brooklyn. He is also on the advisory board of New York City's Violent Death Reporting System and the New York City Elder Fatality Review Team. We are both pleased and honored to have Dr. Anthony Rosen with us today. Tony, take it away.
I think I'm on mute. I apologize. Hi, I'm going to try that again.
Okay.
This is Tony Rosen. Thanks, Dr. Stahl. I really appreciate it. I am delighted to join you guys. Thank you very much for the opportunity to present. And also, excuse me, as Dr. Stahl said, I'm an ER doc. And so from my perspective, and you'll hear this in my presentation, I think there's a real role for the emergency department and for those of us that provide emergency care in identification of elder abuse and in intervention. And what I'm going to discuss today are some of the findings from the forensic research that myself and many, many colleagues have been working on. So first, as Dr. Stahl said, I'm very, very lucky to be the recipient and to have colleagues who are the recipients of funding from many different organizations, including NIH, but I have no financial conflicts of interest to disclose. So elder abuse. I know you're all here because elder abuse is something that you're focused on, that you care deeply about, but again, just sort of as by way of introduction, elder abuse is common and has very, very serious consequences. We think that as many as 10% of older adults experience abuse or neglect each year, and their victimization increases risk of mortality, emergency department presentation, hospitalization, nursing home placement, depression, and many, many other medical, socio-medical, and other negative outcomes. Unfortunately, despite the fact that elder abuse is common and has very serious consequences, it is dramatically under-recognized and under-reported. The literature suggests that as few as 1 in 24 cases are identified and reported to the authorities. And I know that many of those of you who are on this webinar are the authorities. And so it's important that we identify ways to improve reporting of these cases and making certain that they get the kind of intervention that is necessary. So again, I'm a doc. And so I think that from my perspective and from many of those that work with me, the evaluation by a healthcare provider might be the only time that an abused older adult ever leaves their house. And so as a result, it is a critical opportunity to identify elder abuse or neglect and begin intervention. After all, and again, I'm biased as an ER doctor, but I would say, and the literature clearly supports this, that abuse victims are less likely to see a primary care provider and more likely to present to the emergency department. After all, we're the doctors that typically manage acute injuries and illnesses. If you present to your primary doctor with a wrist fracture, they're going to send you to the emergency department. In addition to that, the emergency department, I'm sorry, it looks like, thank you. So the emergency department also is an ideal opportunity to identify and intervene. After all, we think of the ER as a unique place. There are varied disciplines observing a patient. So we have not just the physicians, but also the nurses and the technologists and the radiology techs and the clerks. Everyone is watching the patient. In addition, no matter what we do, no matter how hard I try, the emergency department evaluation is typically prolonged. It typically is hours, as you all know if you've brought family members to the emergency department. And also, and perhaps most importantly, the ER is a place that has resources available 24/7 to intervene if necessary. So ultimately, the ER might be an ideal place to identify elder abuse and intervene. Despite this, however, the literature is very, very clear. Research that myself and many, many others have done shows that ER providers seldom identify or report. In fact, as I mentioned earlier, we think that as many as 10% of older adults are victims of abuse or neglect each year. Just to give you a framework for how often elder abuse is reported from the emergency departments, it's reported in 0.01% of emergency department visits. So that gives you a sense of how often we're missing it. So why are we missing it as ER doctors? Well, there are a lot of reasons we're missing it. Lack of time to conduct a thorough evaluation, lack of awareness among emergency providers or inadequate training, fear or distrust of the legal system, and I apologize for the many folks in this audience that are part of our legal system and part of our justice system, denial by the patient him or herself, ambiguities surrounding the decision-making capacity of victimized older adults, absence of a protocol for a streamlined response, and difficulty distinguishing abuse from accidental trauma or illness. And in some ways, this is one of the most important, and it's what I'm going to talk about today. These are the challenges of what we might refer to as elder abuse forensics. Fall is the most common reason for anybody of any age to present to my emergency department is older adult coming in after a fall. And so how do we distinguish falls from things that, gee, you're saying it's a fall, or the person standing next to you is saying that it's a fall, but I'm not so sure? It turns out that forensics are critical, and I'm sure that many of you, I saw the list of participants, many of you have experience in child abuse. Forensics, or distinguishing injuries that are associated with accident from injuries that are associated with potential intentional injury, is a cornerstone of child abuse detection. I'm showing you here a couple of the critical articles. The first article was actually published in 1962 by Henry Kempe called The Battered Child Syndrome. And the most recently, there's another recent very prominent article saying those who don't cruise rarely bruise. And I've given a list here of all of the different types of injuries that are known to be very, very suspicious for child abuse. And as a clinician, as an ER doctor, I'm qualified to see patients from 0 to 105. This is what we use. It's this list that we use to say, well, gee, you say it's fall off the monkey bars, Mom, but I'm not so sure that this is fall off the monkey bars. Forensics has been a critical cornerstone for radiology and for emergency physicians and for clinicians of all stripes, as well as for the legal system, to identify child abuse detection. However, elder abuse turns out to be harder. The first problem is that it's just harder to identify elder abuse. There are physiologic changes of aging that make your skin thinner, that make your bones also weaker. You're on common medications like aspirin or Coumadin or blood thinning medications that make it much more common for you to bruise easily. Older adults have varied functional status. We have 85-year-olds that are windsurfing that I care for, and 71-year-olds that are dramatically functionally dependent. And so age alone doesn't give you enough clues to distinguish whether a patient is likely a victim of abuse or neglect. Also, there is much less evidence, and this gives you a little bit of a framework for why I'm here talking today. It turns out when we started our work a few years ago, we noted that there was more than 1,000 peer-reviewed articles describing child abuse injuries and distinguishing them from accidental injuries in children, versus when we started 5 articles. And as an aside, and I'll mention this a few more times in my presentation, but you heard recently, if you participated in an earlier seminar from this series from Laura Mosqueda and Paige Ulrey, who are colleagues, mentors, and really wonderful friends. And of the 5, 2 of these articles that were in existence were from Laura Mosqueda and her work and her group's work in Southern California. And she discussed some of that work on a recent webinar that I know from my colleagues that are working on these webinar series at DOJ, that will be available in the next few weeks. But it gives you a sense of where we're starting. So what was the objective of our research? The objective of our research was to identify injury patterns associated with physical elder abuse, essentially to try to give people tools to say, well, you're saying it's a fall, but I'm not so sure. Here's the problem, though. If you're a researcher, and I know that some of you on this call are researchers, how do I identify cases of abuse to study in detail if, after all, I only identify it, or my colleagues and I only identify it in emergency departments 1 in every 10,000 cases? I might be doing research for decades before I get enough cases to say anything meaningful. And so what we decided to do was to partner with folks in the justice system. And so what we did was decided to look at legal files of cases that had been already adjudicated, where the perpetrator had either pled guilty or been convicted. After all, these are cases where abuse is indisputable. And we looked at these legal cases. In fact, I still have an ID from the Brooklyn District Attorney's Office, and if there's someone from Brooklyn on the call, thanks again for your partnership. I've been on the 20th floor of the Brooklyn District Attorney's Office for the last 2 years looking at cases, looking at legal cases, looking at the photographs that our colleagues in law enforcement took, looking at photographs that emergency department folks took, looking at medical records that were subpoenaed and added to these legal case files. So in some ways, I'm one of the only medical researchers, I suppose, that's doing research in the legal world, but it's been a critical way for us to improve our understanding of what kind of injuries people suffer when they're suffering from physical elder abuse. But remember, it's not enough to know what kind of injuries abuse victims suffer from. What's more important is to be able to distinguish those from the falls or the other accidental injuries that we see every day. And so what we designed, and the research that I want to talk to you a little bit more about today, is what's called a case control study. And if there are any epidemiologists in the audience, a case control study describes cases and compares them to control subjects who are not exposed to this type of violence. And so what we've done is compared injury patterns, physical findings, and forensic biomarkers, including forensic photographic evidence, from physical elder abuse victims, these cases that we examined from Brooklyn, and compared them to geriatric patients presenting to our ER after an accidental fall. Patients who we also screened for elder abuse to make sure that they were not themselves victims. And so this is the research that I want to report to you on. Can we find injury patterns that are common in abuse but uncommon in fall or accidents? So the first thing is this. It turns out, and those of you that are clinicians on the call will certainly be familiar with this, that even if I were to look at medical charts from the patients that we saw in our emergency department, many of us don't do a great job as emergency clinicians documenting every little injury. We will certainly document a gunshot wound or a deep stab wound, but if you have a small abrasion on your arm, it's certainly likely that the emergency physician may document it a little bit or may not document it at all. Certainly not enough for research. And so in order to compare the injuries that we were seeing in the photographs of our elder abuse cases to injuries that our fall victims suffered, we decided we needed to take pictures in our emergency department. And so the first thing that we did was to look around for protocols for how non-photographers could take photographs of acute injuries. And we were disappointed initially to find that we could not find any such photographic protocols. But often, as you know, challenges turn into opportunities. And one of the first components of our research that I want to talk to you about, and I know that Dr. Stahl wanted me to talk to you about, was our forensic protocol. And so what we've done is this. We developed a protocol for our research team to photograph injuries in the acute care setting. And this protocol has subsequently been published and is available. I know that there are many in the law enforcement community that are interested in using it, and it's certainly widely available, and we're happy to send it to you if you're interested. And as you can see in the bottom right corner of this slide, this is the academic citation for the paper in which it was published. Let me tell you a little bit about this protocol. The general principles of this protocol, and we really envision it as a guide for folks who want to take the optimal photographs for future justice and for future research and for medical long-term tracking of acute injuries. The general principles are to include identifiable information from the patient, if appropriate, to use a ruler and color guide, to take photographs at a 90-degree angle, to hold the ruler 1 to 2 inches off the skin, and to cover the patient as much as possible. And you can see here that we recommend 4 photographs of each injury, and we're giving guidance on how to take those distance and close-up photographs, and then super close-up images as well for small injuries. In addition, we've broken up the body into 8 body regions, and we're describing appropriate body positioning and how to take these photographs optimally for each of these body positions. Particularly, of course, we want to keep in mind that these are patients who are often in acute pain. And so we want to make sure that we're being sensitive to moving them as little as possible and avoiding additional pain. And this gives you a sense of some of the meat of the protocol. It's showing in individual diagrams, descriptions of how to take the photographs based on individual injury location. And then here are some of the, is a sample rather, of some of the injuries taken with this system. So you can see distance photographs and close-up photographs with and without a ruler that allow you to see the injury in detail. In addition to the photography protocol, we needed in our research to describe injuries in very significant detail in order to compare them carefully and closely. And so the other thing that we were looking for was a comprehensive classification system and taxonomy to describe geriatric injuries. And a comprehensive classification system and taxonomy to describe geriatric acute injuries, particularly visible injuries. And designing that was a lot of fun because it gave several of us the opportunity to work with our anatomy professor from medical school. But we're hopeful that these two pieces of methodologic advancement, hopefully, our photographic protocol and the classification system, will be methodologic tools that other researchers can use and other researchers perhaps can improve on so that we can compare our results apples to apples. And so we're hopeful that these methodologic pieces will be useful to the field in general, as well as being critical elements of the work that I'm going to tell you about now. So let me tell you where we are. We've examined 100 cases of physical elder abuse, and to give you a sense of the field, this represents the largest case series of physical elder abuse cases that we know of that's been closely studied like this. And we've enrolled 300 fall victims from our emergency department to serve as control subjects. And this gives you a very brief sense of some of the findings that we have so far. First, you can see that bruising and laceration, which are, a laceration is a cut that requires stitches, for those of you that are not medical folks, a deep cut that requires stitches. Bruising and laceration are more common in abuse, whereas abrasion and fracture are more common in falls or other, in this case, in falls. Additionally, if we were to look at body regions injured, the maxillofacial dental neck area, or the patient's face, forehead, mouth, and neck, are much more commonly injured, as are their chest, abdomen, and back, and skull and brain among abuse victims. But the lower extremity, which are the legs, and the pelvis buttocks, or the hips, and the bunsies, as my 5-year-old and 2-year-old call them, the bunsies are much more commonly injured in falls. And so this gives us the beginning of a ways to distinguish. But remember, these are not necessarily specific enough to give tools to clinicians examining a patient in the emergency department on what they can look at to distinguish. And so we also looked on precise locations. As I mentioned, in the comprehensive taxonomy, we described more than exactly 277, or I'm sorry, more than 270 precise locations of on the human body, and we looked at where these injuries occurred more precisely than simply on the face or on the back. And we found some pretty interesting things that we think are helpful. The first is the left periorbital area, or the left area surrounding the left eye. As you can see, That's much more common in abuse and physical abuse than it is in a fall. And it turns out for those of you that work in other types of family violence, this actually supports the existing literature in younger adult assault victims, which has shown that left-sided facial injuries are more frequent after assault than right-sided, likely because most assailants use their hands and their fists and are right-handed. And so the left periorbital area is much more commonly a site of injury in abuse. In addition, the ulnar forearm, and I apologize in advance, I can't see you guys, but I'll certainly hold up my hand and try to, if you hold up your hands in the audience, you can see that there are two aspects of the forearm. There is the thumb side of the forearm, that's called the radial side. The doctors call that the radial side. And then there's the pinky side. And the pinky side is the ulnar side. And it turns out that the pinky side is much more commonly injured in assault than it is in a fall. I'm going to talk about that in a little bit more detail in the future, but it's very interesting that the pinky side of the forearm is much more commonly injured in assault than it is in a fall. And that confirms previous research, and specifically, that confirms the previous research that Laura Mosqueda discussed with this group a couple of weeks ago. In fact, in the bruising work that she and colleagues led by Aileen Wigglesworth did, it turns out that the ulnar forearm, or the lateral forearm they called it, was much more commonly bruised in victims. And if you were to examine your own pinky forearm and hold it up above your forehead, you would find that it's the ulnar side, or the pinky side of your forearm, that you use to defend yourself if someone were striking you. And so that's another interesting finding, and a finding that is supportive of existing research. The third thing that we found was the neck. And as you can see, the neck is much more commonly injured in assault than it is in a fall. And this confirms our finding, our previous finding from our research of the National Trauma Data Bank. And in addition, if you were to think about it, after all, the neck is uncommonly injured in a fall. When you fall, your neck is protected by your face, and your neck is also protected by your shoulder. And so unless you fall against the edge of a bookshelf, the likelihood that your neck is immediately exposed to the ground is low. In addition, if you felt around on your neck, you would find that there are no large bones right under the skin, no bony prominences, making bruising even less likely. So as you can see, we have three things that are the beginning. And I want to highlight the bottom two, ulnar, forearm, and neck. These are things that are very uncommon in falls in our research. Very uncommon. And given that they are very uncommon in falls, they may represent the beginnings of what we call in medicine potentially pathognomonic injury patterns. Injury patterns that strongly suggest assault or abuse and really are uncommon enough in accidental falls as to be very, very unlikely associated with that type of injury. These are the kind of injury patterns that allow child abuse detection to occur efficiently, and also these are the kind of injury patterns that allow our colleagues in law enforcement, and particularly in prosecution, to say this kind of injury is inconsistent with this kind of reported mechanism. And so I think from our perspective, we're continuing to do research, and we're excited to move these findings forward, but this is the beginnings, we hope, of the next steps for this type of research. And so our preliminary conclusions are these, that specific clinically identifiable differences may exist between unintentional injuries and those that occur from physical elder abuse. That bruising and injuries on the maxillofacial dental region, particularly in the left periorbit, are more common in abuse, and injuries to the ulnar forearm and the neck occurred in abuse but very seldom in accidental injuries. For those of you that are focused on research, and frankly for those of you that are not necessarily primarily researchers, I want to make sure that I emphasize our limitations in this very preliminary research. The information that we studied was primarily in legal case files, never intended for research. The information was often incomplete, with photographs and or medical records missing for reasons that were out of our control. Perhaps they weren't taken. In some cases, the medical records had been drowned by Sandy, Hurricane Sandy. Some of these records have been stored in a basement. Our focus on highly adjudicated cases elucidates the characteristics only of the elder abuse victims that have been identified. After all, our goal is to increase identification. And if we only focus on cases that have been identified, we're going to be not yet doing a great job on the cases for which the diagnosis or the identification is ambiguous. The comparison of ED fall victims may differ significantly from cases in unmeasured ways, and the patterns of elder abuse injury in our single urban area may not be generalizable elsewhere. Of course, we are thinking already about future research and next steps, and for those of you that are research folks, what we've done is what we would refer to as a retrospective study. We've looked backwards at cases that were already identified. And our next steps and the work that we are currently engaged in, and the work that I want to thank the NIA for the generous funding for, because it's the Beeson funding that Dr. Stahl mentioned. Much of the Beeson funding is focused on this research project. We are now prospectively enrolling and comprehensively evaluating victims of physical elder abuse in our emergency department to test our injury pattern findings. And also we're hoping to derive and validate a clinical prediction rule to assist busy clinical providers in identifying physical elder abuse. And so I know that we have a very varied, I apologize for using that word twice, a very varied audience. And so I want to pause for a second to explain what a clinical decision rule is and how that we think fits in with the research that we and others are doing in this area. A clinical prediction rule, and these are used every day by a wide variety of physicians and other clinical providers, is simply something to help make decisions. And so imagine a rule in the future that said, here are the 7 things that we'd like you to look for when you're seeing an older adult with a fall. And if an older adult with a fall has more than 4 of these things, you need to think about elder abuse and ask them more questions. And if this older adult fall that you're examining has all 7, then you need to think very seriously about elder abuse. That's the kind of rule that we're hoping to build in the future, that we're hoping to work with colleagues like Dr. Mosqueda and Paige Ulrey and Tim Platts-Mills, who was mentioned, who's an excellent researcher in this area and collaborator, and to many, many, many others. But that's our goal, ultimately. I want to also talk for a moment, perhaps there are some in the audience, and certainly there are some who are aware of the role of radiologists. And so I think that when you think about child abuse forensics, I think that you'll find that child abuse forensics radiology is a critical element of child abuse forensics. They play a critical role in the detection of child abuse in the emergency department and in any clinical setting. In fact, child abuse detection is a core part of radiographic practice, and diagnostic radiologists train very extensively on how they can contribute to child abuse detection. Despite this, imaging correlates of elder abuse have not been described at all in the radiographic literature. In fact, when we started looking at it, there was only 1 manuscript in the entire extant literature. And so what we did was we interviewed radiologists. and we asked their perspectives about elder abuse detection. And here's what we learned. First, few radiologists reported having received any formal or informal training at all in elder abuse detection. And frankly, even experienced radiologists reported never having received a request from a referring physician to assess images for evidence suggestive of elder abuse. Memorably, one physician said, "Tony, I've been doing this for 17 years and no one's ever asked me that question." But we pressed and we said, wait a second. Even though no one's ever asked you, now that we're asking you, do you think that there are imaging correlates, that there are things that radiologists could look for that might be suggestive of elder abuse? And the radiologists that we talked to said the equivalent of, well, sure, there absolutely are. And they listed these, and these were presented in a paper that we published in the radiology literature in the last 6 months. Upper posterior multiple rib fractures, multiple subdural hematomas. These are types of intracranial hemorrhages, or I apologize, bleeds inside the skull, bleeding inside the skull, a fracture or a break of the skull, small bowel hematomas. This is bleeding inside of the intestines, injuries in multiple stages of healing, injuries inconsistent with the reported mechanism, multiple fractures and head trauma in the same patient, a spiral fracture, which is a specific type of fracture pattern in a long bone, brain volume loss secondary to malnutrition, and extensive decubitus ulcers, which can be viewed on imaging. And so as you can see, there's a pretty extensive list here that radiologists might be able to use in the future, that researchers in radiology and researchers like me and hopefully many others on the call can try to add evidence to support, because these are right now just suggestions. But I also want to tell a radiology story, because I think that also illustrates how we can all work together. I was working with Arlene Markarian, who's now in the Nassau County District Attorney's Office, but was at the time in the Brooklyn, or what you call Kings County District Attorney's Office, and she's a wonderful elder abuse advocate and prosecutor, someone that I think many on the call on this presentation likely know personally, and certainly if not have likely been trained by. She and I were reviewing a case together, and in this case, the victim, an older adult in his 80s, reported being struck by a cane. And the alleged abuser, who was his girlfriend, or at least she self-identified as his girlfriend, who was 25 years younger, said, "Oh, he drinks a lot and he fell. It's not true. I didn't hit him with his cane." And I spoke with a radiology colleague in our hospital, and we looked at the x-rays together. And it turns out that he had what's called an ulna fracture, a fracture of the ulna. If you remember from your, I apologize, anatomy lesson from a few minutes ago, the ulnar side of the forearm is the pinky side. And the reason we call it the ulnar side is, if many of you think back to either college anatomy, high school anatomy, or even perhaps 7th grade, it turns out that the forearm has 2 bones in it. The 2 bones in the forearm are the radius, and the radius is on the pinky side, on the thumb side, or on the radial side, and also the ulna. And the ulna, of course, is on the pinky side or on the ulnar side. And it turns out that the radius breaks all the time. What's called a distal radius fracture is very, very, very common. In fact, I've probably cared for on the order of 2,000 or more distal radius fractures. I actually worked in the ER last evening and overnight, so I apologize if I'm a bit scattered during this presentation. But overnight last night, I cared for 2 separate distal radius fractures in older adults who fell. It is very, very common. But an ulnar fracture is very uncommon. And this is what my colleague, Dr. Mennett, said. The ulna does not even anatomically support the wrist. So you would not expect a distal or mid-shaft ulnar fracture after a foosh, which is a doctor word for a fall on an outstretched hand. And so from his perspective, ultimately, the ulnar fracture that we saw in this patient was much more supportive of a defensive injury from a cane or from another object, and not at all supportive of the fall. And in some ways, this is the beginning of a role for radiologists in elder abuse forensics. And also, as a reminder, it supports the research that I described to you just a few moments ago, that the ulnar forearm that Laura found in her research, that we found in our research, is much more commonly injured in physical elder abuse, but not in unintentional falls. And so hopefully, for those of you on the call that are interested in radiology or interested in radiology research or interested in the role that our imaging colleagues can have in elder abuse forensics, I think that we are at unequivocally the beginning, but hopefully a promising beginning as well. And we've obviously published a little bit of work on this as well. So I now have about 9 to 10 minutes left, and I wanted to cover a little bit about where we are. What I'm describing to you is research, or rather what I've described to you is research. But there was a great question on Laura and Paige's call, which was, well, how are we training ER doctors today? And I know the questioner asked about ER doctors, but I suspect the question was not just ER doctors, but also how are we training physicians and other clinicians on how to recognize elder abuse today? How are we training them in the absence of great evidence as we continue to build the evidence base? And so I wanted to share a little bit with you about where we are now. The two citations here, the first is a wonderful Clinics in Geriatric Medicine, an entire issue devoted to medical implications of elder abuse and neglect, and many of the photographs that I'm going to show you are from there. And then also, though there's no relation at all, the standard emergency medicine textbook is called Rosen's Emergency Medicine, and just a few weeks ago, the most recent edition was published, and myself and a colleague wrote the chapter on abuse or neglect of the elderly, and so many of the ideas and the photographs that you're going to see are also in this chapter, and so available to emergency physicians. I don't know how many folks are going to read it, but available to emergency physicians in this fashion. And I give the next slide set that I'm going to show you now, I present all over the country to emergency physicians. I presented at a national conference relatively recently. I presented this slide set to NYPD here in New York City and to other service providers. And so this gives you a sense of what we're trying to teach. And again, I emphasize on the word of trying, but we're trying to teach our colleagues what to look for. Because we're in emergency medicine, certainly visual diagnosticians. And so before I go any further, I want to make sure that I emphasize that we're going to look at some photographs for the next few minutes of physical signs suspicious for physical signs suspicious for potential elder abuse, physical abuse, sexual abuse, and neglect. And before I begin, and I know you heard this from Lori at the beginning, or Ms. McGee from the beginning, these are graphic photographs. Unfortunately, for those of you that work in this area, you know that these are graphic cases. And it's important for us to look at these things, but I want to make sure that before we begin, I emphasize that again, so that folks that aren't comfortable or aren't interested in looking at these photographs can either go to audio or sign off this part of the webinar. But let's talk about what we're looking for. Because remember, some falls are actually abuse. What are we looking for? Well, in physical abuse, we're looking for bruising in atypical locations. Not over the bony prominences, on the lateral arms, on the face, on the back, on the ears, or on the neck. Here are some examples. For patterned injuries, bite marks, injuries consistent with the shape of a belt buckle, fingertip, or other object. And here are some examples of a fingertip patterned injury or of an object patterning. Wrist or ankle lesions or scars. These are among the most upsetting. They suggest restraint, but it's important to look for them. Burns. I would say, as an emergency physician that works at a burn center, any burn in an older adult should be concerning, but particularly the so-called stocking glove pattern suggesting forced immersion or the cigarette pattern. And again, those of you that work in child abuse are probably hearing this and saying, gee, these sound like similar patterns to what I'm taught and what I teach in child abuse. And there is no accident. That is unequivocally the case. Multiple fractures or bruises of different ages. Here's an example of bruising, and here's some radiographic examples of multiple rib fractures of different ages. Traumatic alopecia. That's another doctor word, and I apologize for giving you too many doctor words during this talk, but traumatic alopecia is a clump of hair that's gone. Clumps of hair are not supposed to be just gone with blood. Hematomas or swelling or bleeding in the scalp. Subconjunctival vitreous or retinal ophthalmic hemorrhages. These are hemorrhages inside the eye, either deep in the eye or on the surface of the eye, bleeding in the eye. And then intraoral soft tissue injuries. What I always teach my residents is you can learn a lot about an older adult by looking inside their mouth. You need to examine the inside of older adults' mouths. And so if you see soft tissue injuries inside someone's mouth, and by soft tissue I mean bleeding and other injuries inside their mouth, you need to look more seriously. Sexual abuse, genital, oral, or rectal trauma, and evidence of sexually transmitted disease in somebody that is not thought to be sexually active. This includes, the trauma includes redness, bruising, or cuts. And you can see here, you're just not supposed to have this pattern of injury up in this part of the upper thighs. And in fact, myself and a colleague, Lena Macaroon, have been working with the Seattle District Attorney's Office on a case of this, in Seattle PD. And evidence of sexually transmitted disease. Neglect. Neglect is perhaps the hardest to find. And in addition to being the hardest, it is unequivocally the most common and the most commonly missed. So what are we looking for? Well, we're looking for dehydration and malnutrition. Malnutrition, we typically look for muscle wasting, temporal wasting. The temples are right, of course, on the sides of your forehead. Sunken eyes, someone that looks like they lost a lot of weight. Dehydration. Dry mucous membranes, that's dry lips, chapped lips, sunken eyes. Skin tenting, that's when you pull someone's skin up and it doesn't go back down when you pull it up. Severe constipation or fecal impaction may suggest this. Pressure sores or decubitus ulcers. This is among the most challenging things for those of us that work in this field, because even with excellent care, in some cases pressure sores and decubitus ulcers are going to develop, but these kind of things shouldn't develop. And these are the things to look for. Also, heel ulcers are commonly due to restraint, and they are evidenced by circumferential ankle bruising and heel ulceration, and those are particularly concerning. And so that's not an area that's typically ulcerated in good care. Poor body hygiene and unchanged diapers. Again, I apologize for the graphic nature, but this is important for us to discuss. Severe, dirty and severely worn clothing. Elongated toenails. Again, I tell my residents when I train them as an emergency physicians, you got to look at an older adult's feet. You got to look at their feet. You can learn a lot from an older adult's feet, and you can't care for an older adult without looking at their feet, and this is what you might find. And this can tell you a lot about potential neglect. Also, I mentioned that looking in the mouth is critical. It's critical not only for injuries, but also to look for very poor oral hygiene, which may also suggest neglect. So as you can hear, there are a lot of physical signs that we can look for as medical clinicians, as social science clinicians, as community workers, as law enforcement workers that can help us to be concerned, and if we're concerned, can help us to substantiate that concern. Also, these are things that we can train our colleagues to look for to raise their suspicion as well. The last thing I want to cover, and I know I'm nearly out of time, is to tell you for just 1 minute about one of the things that we're doing. We recognized in our emergency department that there are child protection teams in our ER and throughout the country, in over 1,000 ERs, certainly in several hundred ERs, that allow for ER providers to essentially press a button and call in the cavalry. if there's a case of child abuse or potential child abuse, they can involve a multidisciplinary team, and the ER folks can turn back to the heart attacks, strokes, and traumas for which we are trained. And even though there are many, many child protection teams that have been around for more than 50 years, there are no, that we know of, current ED-based elder protection teams. And so we've designed one. We designed one and just launched in April. And we're trying to, we have designed and we're trying to work on a consultation service available 24/7 to assess, treat, and ensure the safety of elder abuse and neglect victims, while also collecting evidence when appropriate and working closely with the authorities. And we're hoping that this increases identification and reporting and decreases the burden on ED providers. After all, time and concern about a response, as I mentioned, were two of the critical factors that prevent ED docs and other ED providers from reporting today, and we're hoping that this will help that. Also, we've modeled this similar to existing child protection teams, and I look forward to reporting, I shouldn't say I, my many, many colleagues and collaborators and I look forward to reporting on our findings for this program in the future to groups like this. So with that, as you can see, there's an enormous number of people for me to thank, not the least my kids in the bottom right corner, but also many people that are on this call and many, many people that contributed to my work in this field, and most importantly, all the work that we do together in this field. So thank you very much to Dr. Stahl and to Ms. McGee and to DOJ and to everyone for giving me the opportunity. I hope this has been helpful, and I look forward to responding to questions.
Tony, thank you very much. Several people have asked a question about the photo protocol that you have, and if you write to the address that's on the screen now, we'll make sure that we either send this on to Tony or somehow get the protocol itself to you. Tony, do you want me to ask the questions? I think you see them at the bottom of your screen as well. Or do you want me to?
I do, but Sid, if you think there's a first question that you think is most germane, feel free to ask it, and then I'm happy to follow on from there.
Okay. Well, Audrey Sebastian asked the question that she is a 911 dispatcher and does not physically see the people, but she talks to them obviously on a daily basis, and I wonder what her role would be in what you're talking about now. How can you tell if it's truly abuse over a phone, or can you tell if it's truly abuse over a phone, or neglect, or is it a sign of dementia? Have you experienced this problem?
That's a wonderful question, Audrey. Thank you very, very much for that question. And I think that ultimately, I think that your role, Audrey, should start, from my perspective, in the following way. Many of the folks that you receive and respond, that you're hearing conversations with, aren't necessarily thinking about it. And so if your role in a 911 dispatcher, I think, is to think about it and to consider it, because many of your EMS colleagues, many of the folks that you dispatch, might not be thinking about it. And so I think your role, and I think a wonderful role that you can play, is to ask a few more questions, and when you receive these calls, if in fact you're talking to the 911, if you're part of the 911 receiving system, but perhaps more importantly, to ensure that the providers that you are sending to the scene are thinking about this. There's a saying in the medicine that you can't diagnose what you haven't thought of. And one of our roles as emergency providers, I think, is to encourage our EMS colleagues to think very, very seriously about elder abuse and neglect. And I don't want to take too long to respond to this question, but I think it's such a great question. I'm an emergency room physician, and so I actually probably am not in the best possible position to identify elder abuse and neglect. Perhaps that person is the EMS provider who goes to the home, who can see the older adult right after 911 is called, who can look in the home environment, who can look to see whether the home environment is safe, who can see whether there are appropriate medications or 6 bottles of the same medication, to watch the interactions between the caregiver and the older adult. And so from my perspective, Audrey, one of the things that you can do that's critical is, if you're receiving calls from 911, ask the questions of the person giving you the call that might give you more clues as to whether you should be concerned or whether EMS should be concerned. And then when you provide the call to EMS, make sure that they're aware of your concerns. Make sure that they're also thinking about abuse or neglect. Make sure that they're also doing the routine evaluation that's important for EMS to do. One thing that I can say that I always train our EMS folks, and in my hospital setting, I have one of my roles is to train EMS providers on this and other geriatric issues, is I say an EMS provider shouldn't go to an older adult's home and pick them up for 911 without also opening the refrigerator and looking to see if they have food. And so from my perspective, Audrey, one of the things that you can do is ask more questions, and then when you're dispatching EMS folks, make sure that you plant in them your concerns and encourage them to follow up with specific evaluations for this. So hopefully that's a helpful answer to that question.
Okay, Tracy Simon asks the question, how do you make sure that any picture taken can be used as evidence in a case? What have you found most successful in getting prosecutors interested, if you will, in a case, since they have so much latitude in what they decide to prosecute and not prosecute?
It's a great question. I think that as forensic folks, as folks with a forensic focus, I think that one of the things that we can do is one of the things that I've tried to do, and many of us are trying to do, is try to make the medical records as accurate and as complete and as forensically focused as possible. And I think that one of the things that we can do as physicians and as clinicians that see the patients is make sure to document as completely as possible and to take as many photographs as possible. However, in answer specifically to her question, I think that the first thing that you want to do is make sure that you have consent of the patient to take the photographs, if that's possible. Although, remember, I'm not a legal person, I'm an ER physician, but also that you take the photographs with identifying information in the photographs, and that you take as many photographs as possible and using a protocol like ours, such as ours rather, so that you can be confident that you're completely showing the injury itself. And so I think that from a forensic perspective, I think our forensic colleagues in DA's offices and elsewhere most commonly complain, for lack of a better way of saying it, to us, that there are inadequate photographs, there are incomplete photographs, the photographs are unintelligible, that don't have clear evidence that this is in fact this patient. And so that is what I would focus on from photograph perspective. And then to the other half of your question, Sid, or Dr. Stahl rather, I think the other thing that I would say is that I think that our key role as frontline clinicians to get our DA colleagues interested in these cases is to give them the best case possible. The way I teach our residents is the more forensic information you provide, the more likely you are to help a victim obtain justice. And so the more clear and complete the documentation is, the more photographs you take, the more steps you take, I think the more likely the DAs are to be interested in collaborating with us on these cases.
Okay. And it's probably time for one more quick question. I'll try to integrate two questions I've had. One from Michael Hagenlock, I believe. Forgive my pronunciation if it's wrong. How would you suggest we provide training in hospitals on this subject matter? And a very related one from Brooker Noti, I believe. Are you aware of either any institutions that provide this kind of training, or are there any kind of self-training guides that you can provide that have been produced in the literature?
Good question. Let me again try to have a short answer. The short answer is that we've developed something that we use to train our folks in our hospital, and I'm more than happy to share that with anyone that's interested, and we can certainly work together. I do think that the answer for hospitals, given the way hospitals typically train people, is the easiest thing for us to do, and we've developed it for our hospital, is a short self-training web-based module that we can either hopefully make mandatory, and in our case it is mandatory for ER providers, but they can at least make optional and hopefully make mandatory for providers inside hospitals. And so I think a logical first step is an online module, and please, if you are the folks that asked this question, please reach out to elder.justice at usdoj.gov, and they can reach out to me, and we can connect and find ways to share this information. I'm also happy to share other resources with you for this as well. But I think that's a wonderful question, and it's a great way to end, because I think that from our perspective, it also answered Audrey's question, which is the more people we train about this, the more people that we have thinking about this as part of their practice, the more likely we are to see it. After we trained folks in our hospital, we got many, many, many more calls from our colleagues saying, you know, I'm kind of concerned about this. I don't know that I would have remarked on this a month ago or a year ago, but now, given what you taught me, I'm concerned. And I think that's where we want to head.
Very good. Thank you very much. And again, as Tony just mentioned, as Dr. Rosen just mentioned, if you write to the address that's on your screen right now, we'll make sure, requesting some of this information, we'll make sure that Dr. Rosen gets it. Dr. Anthony Rosen, Tony, thank you so much for a very fascinating and insightful webinar. And thank you, everyone, for participating. So long.
Thanks very much.
That concludes today's webinar. Thank you.